So happy to see many friends. Sorry to be late. That's not unusual today.
Yes,
There you go. Okay, so I'm going to try to briefly talk about this immunological resilient concept. Okay, the hypothesis that we raise here is whether there is an association between the biomarkers levels indexed by the immunological health grade system, depending on different factors, depending on age, depending on sex, comorbid conditions, and outcomes in general. So what is resilience? So if we look at it in the dictionary, it's the capacity to withstand, to recover quickly from difficulties. And this is what we believe is happening in the immunological system at the time of infection. So when COVID started, we all were very, very concerned. All these people were dying. We needed to do something. And what we tried to do was characterize something that we have been chasing from before in different infections, such as influenza or any other conditions like HIV and AIDS. So we organized this immunological resilience pattern based on these two factors, CD4, CD8, and the ratio. And depending on the amount of cells that we have on the CD4 count, Julio, how can I? Okay. The CD4 count, if it is more than 800, we consider that this patient is immunocompetent. Therefore, that the lymphocyte response is appropriate in amount and that the ratio is appropriate. If we contrast this level 1 with level 4, the CD4 counts are down and the ratio is high. What does it mean? The ratio is low. What does it mean? We see this in patients with HIV. We see this from way, way before that there are certain patients that cannot respond. In pneumonia, we know from Rosario and Raul, very nice studies on lymphopenia. And they have really shown very elegantly that there is an association between lymphopenia and poor outcomes. But how can we relate to this? What we consider is that this immunological health grade 1 is the immunological health grade that we consider immunocompetent that will less likely develop inflammation. And we contrast this with the immunological health grade 4 that is, as I mentioned earlier, AIDS. When we subdivide the groups in the immunological health grades in 1 versus 2A, 2B, 2C, 3, 4A, 4B, 4C, depending on the number of cells, we identified that there are some patients that have very, very low amounts like this 2C and 4C that are severely lymphopenic. And we tested every one of those with HIV, and they were HIV negative. So this is people that comes to your ICUs, to your hospitals with community-acquired pneumonia infection or COVID that are severely lymphopenic at the time of presentation. So we did this longitudinal cohort study at the time of COVID-19, 2,000 patients at baseline, and we look at these different outcomes, but to define the immunocompromised status and the inflammatory phase, we did the same biomarkers everyone did around the world, and we characterized the cells in BK cells and neutrophil cells and the same immunological health grades based on CD4 and CD8. This is a scheme of two types of cells, the B cells, and this is the logarithmic of interleukin 6. So bear with me with this graph. If you really see that level 1 is the good grade, we call it the elite group of healthy individuals that despite of getting COVID-19 and despite of getting into the hospital, their immune system is better based on the number of B cells that is much higher in a dose-dependent fashion, depending on the number of T cells. The IL-6, there is a dose-dependent effect on the lower the inflammatory phase, the higher the interleukin expression was. When we look at patients that were non-hospitalized, had the best marker with the lowest inflammatory, with the lowest IL-6, and the very good number of B cells, in contrast with the people that did not survive. So those survivors had less B cells and higher levels of IL-6. So this is what we all talk about, high inflammation And when we look at this in the H group, the older people had less B cells, higher inflammation based on IL-6, and the younger people much better, and the females were protected. The gender that is the more powerful one is definitely more represented by less inflammation and compared to males. When we look at these different biomarkers, when we compare the immunological health grade group 1 versus the other groups, you notice that blue is good. Blue is the people that laugh at the whole story. You know, I got this COVID, nothing happened to me. I am completely immune. I don't even need a vaccine. I'm doing fantastic. Group 1, okay? So these people were predetermined before the whole start of the story to be good during the infection. If we compare it here, we see that high number of NK cells and B cells was more represented in the group that was the good one, the elite group, the group 1. In contrast, all the other groups had higher inflammatory levels with the dimers coagulation, the CRP, the ferritin levels, the IL-6, the neutrophils, and this is a marker of inhibition for the vaccine that I'm not going to talk about. When we look at the same markers, depending on the age of the patients, you see that the older we get, the less number of B cells we have. However, you can recognize that the two groups that were the more vulnerable, the 2C and the 4C, were the ones that did the worst, and the blue group, the IHF1, did the best. When we look at other markers like C-reactive protein, you notice the same story. And here we have the comorbidities, because the story was we have a lot of comorbidities. The patients have a lot of comorbidities. They tend to do worse. And it's true. These patients with higher comorbidities had higher levels of inflammation. They had worse outcomes. When we look at the different immunological profiles, depending on the immunological health grade, the blue group, the most protected one, had the lowest levels of C-reactive protein, in contrast with the most vulnerable groups, that was the 2C and the 4C. But the interesting part of the story is even if we compare and we do a comparable evaluation between comorbidities that were low and high, depending on the level of immunological health grade, the numbers were very similar across the field. And finally, the mean CRP again, but this one is with obesity. We always said, okay, the obese people, they are going to do worse, they are going to do bad, and we saw it. We saw a lot of patients that were obese and coming with COVID-19, and they tend to do worse. They had higher inflammatory profiles, and these patients, when we look at the C-reactive protein again, in the obese group versus the non-obese group, in each one of the immunological health grades, the group 1 is the highly protected one versus the 2C and the 4C that are the more vulnerable. So with this, we think that there is an association between the immunological health grade group 1 that seems to be predetermined to be protective and is an elite group that are less likely to develop inflammation, that have an immunocompetent status that is much better than the other groups and the other patients. And in addition, that they are more likely be able to cope with the inflammatory phase that comes with the severity of the disease, in contrast with the more vulnerable groups that are not only immunosuppressed, is that they can cope less well at the time of the severe infection. So there's a very, very short story of the immunological health grades. Now, we have done the genotyping, trying to really look at for all the different pathways associated with this, and we have linked this with survival data, with the Framingham study, and we have shown that the people that had the immunological health grade had a genotype that is also protective in the Framingham study, suggesting that the people that live longer is not by random. No, is that these people have a genetic pattern that is more protective than other, and even when we compare it with other infections. Thank you so much.
Well,
questions for Julio? No. I'm too tired.
Another twist of the inflammation immunity. Everything is based on inflammation immunity today. Okay, questions, Marcos? Any comments or questions?
You measured this at what point in time? That when they were acutely ill, right?
Acutely, yes, sir.
So it'd be very interesting to know where they are a month later, or 6 months later. You know, and if these patterns continue, or if, because all the people that you see with poor outcomes, be interesting to know which their initial immune response was.
That's a fantastic question, Mike. We have done it. We have it in the paper. We have the convalescent group that we have followed for 2 years. And it's a very interesting part. So the group 1, the majority goes back to group 1. The people that were 4 most likely will remain on 4. So they have immunosuppression due to multiple conditions such as cancer or chemotherapeutic agents and things like that. The groups in between, there is a variability. Some people recover and some people tend to remain. The people that tend to remain immunocompromised like this are the ones that tend to respond less to vaccination. We have it in the paper. We have these people are more likely to have COVID symptoms, and we're the one that most likely have recurrent episodes of reinfection when we really look at the CT threshold on the viral load and the viral load amount. Those people were having a really hard time to clear the SARS-CoV-2 throughout the infection, and those were the ones that we always were running into to retreat when they presented again. Fantastic question.
Any other comments or questions?